Hello again, everyone, and welcome to Conversations with the Dean. My name is Turney Stevens. I'm the Dean of the College of Business at Lipscomb University, and I'm delighted today to welcome an old friend, a good friend, Robert Chamberlain, back to the campus here at Lipscomb.
Thank you, Turney. It's a pleasure.
Well, we're honored to have you, Bob. Bob, you are the founder and chief executive officer of Applied Health Analytics, a startup healthcare company here in Nashville. Maybe we should start by you telling us what Applied Health Analytics does.
How much time do we have?
Well, we've got 30 minutes.
Well, I'll truncate it as best I can. We are a health software company specializing in the field of healthcare, and we find ourselves between two very dynamic positions within this industry. The first being employers' desire to bend the trend on their healthcare cost, and the second being the hospital side of the equation, which is very much interested in enhancing its margins so that it can continue to provide the services that it does to the under and uninsured. And we're sort of the information bridge between what we like to call the payer, who's the employer, and the healthcare provider. We bring them together in a very meaningful partnership, and everything between those two particular players in the industry is the software platform that we represent.
Well, there's lots of ways we can go with the conversation today, Bob, and hopefully we'll have time to explore a number of those. But let me start with the role of data in healthcare. We've heard a lot about health informatics. We've heard a lot about the need to digitize medical records. How is data going to play a role in the future of U.S. healthcare?
Well, a great question. I think the first thing to begin with is understanding two dynamics that are pushing us into the need for more data. The first is for over 30, now 35 consecutive years, the cost to provide health benefits have only gone up, which should be enough trending data to suggest our current model is broken. The second is the largest payer for healthcare services in this country is the United States government. And as we now know at the federal level, there's a very sharp interest in changing the role of Medicare and Medicaid in terms of its relationship to the budget and cutting those costs. So those two factors are causing the purchasers, the government, private corporations, to start to demand better outcomes. So as a result of that demand, what we're finding out is there's a movement of many companies into the area of how can we create greater efficiencies in the delivery of healthcare services in this country. Well, of course, that's all data-based. Concurrent with that is just the mind-numbing evolution in the quality and the type of healthcare that we're providing in this country. We're moving towards evidence-based medicine. We're moving towards electronic medical records. We're moving towards the warehousing of data sets that now can be made available to a growing number of caregivers that are being associated with a particular patient or a particular event. So, Attorney, I'm not sure if that answers your question, but we have a cost issue, we have a demand issue, and we have just a fundamental changing in the way healthcare is delivered in this country that is saying to the practitioners, that is saying to the payers of the services, how can we better manage these events?
So data becomes a part of the management of healthcare.
Clearly.
As it is in every industry.
Clearly.
There's not an industry out there.
And healthcare, as sophisticated as it is in this particular country, in terms of the delivery of specific services, what we can do with the human eye, what Vanderbilt University is doing with the human genome is remarkable. And it's brilliant in these silo effects, but across the industry, it's really just now starting to understand the importance of data integration among the caregivers.
Well, we've had other guests on this program, and I've used the example of an ATM withdrawal in China. I can go anywhere in the world and get $100 out of my bank account, but I can't go to the hospital nearest my home in Williamson County.
So why can't a physician go to a website, type in the name Turney Stevens, maybe with some credentials required, and access your information?
Sure, and know that I'm on warfarin, for example.
Sure.
That's a critical thing to know in case I'm in an accident in a car, but that digital data is not out there unless I'm conscious and can tell.
Yeah, the federal government and the private sector are pushing us to that.
Now, Bob, your company is focused largely on what I would call wellness, if I can use that term. You're all about seeking to be preventative. I guess one question I would ask you is, are we underdiagnosed in this country? Are we over-medicated? We talk about how much we use pharmaceuticals, for example. What is the big issue that's wrong with U.S. healthcare?
4 questions there. The first is wellness. We want you to use a new term called population health management. Wellness has been around for 20 or 30 years. It has always been the right thing to do. But as costs continue to skyrocket, and to give you an example of what I'm talking about there, in the year 2000, the average cost for an employer to provide health benefits to an employee was about $9,700. Milliman USA, which is a very internationally respected actuarial firm, released the Milliman Medical Index just 2 weeks ago that told us that a family of 4 participating in a PPO product is spending just over $19,000 a year. So we've had a dramatic increase from $97,000 to $19,000 within a relatively short period of time. During that period of time, there's been a lot of movement into wellness. But what we're finding out is more and more corporations are starting to your third question, I'll come back to the second in a moment, more and more corporations are starting to look at early detection, prevention, and education as a means to reduce their claims expense. Why? Because they've gone down the road of case management, they've gone down the road of disease management, which are ways to analyze, where you've spent your dollars, where are the most expensive employees within our claims data, how can we better manage that care? But we're still seeing this cost trend increase. So employers are starting to take a page out of the CDC's book that says, 72% of the dollars we spend in the provision of healthcare services in this country is for the treatment of disease and illness that could have been prevented. We're not exercising. What is it, 63% of Americans are either overweight or obese. As a result of that, we've got an epidemic in type 2 diabetes that is getting ready to spread across this country. And boy, you think we're spending money now, wait till the baby boom moves into the Medicare years and they're overweight and they're diabetic. You're spending a lot of money there. So employers are starting to say, maybe we need to take the CDC up on its information, and we need to find who qualifies for mammography screening, who needs the colonoscopy, who needs the flu shot, the physical exam, the PSA, the pap smear, who needs those interventions, because we know we can, if we find it early, it can be prevented. I mean, what is the data on breast cancer? We currently have a 95%, I might be misquoting this, but a significantly high percentage rate of cure if we find it early. And I think it is in the 90s. So employers are moving very aggressively in that direction. That's at the private level. At the federal level, the federal government is moving in that direction. Much of President Obama's new health care law has provisions in it that incent not only Medicare and Medicaid, but permitting the commercial market to start to incent employer participation in population health initiatives. So for those of us in healthcare, particularly applied health analytics, because you're right, this is the area that we play. For those of us in healthcare, it's very exciting. What's happening in healthcare today has been described by one of our clients is it's kind of the Wild West of healthcare again. People are trying to figure out, what is this new law, where is it going? We're seeing the development of accountable care organizations. We're starting to see, I don't know if you read, but just a couple of weeks ago, PepsiCo announced that there are 250,000 worldwide employees. If they need hip or knee replacement surgery, they can fly to Johns Hopkins in Baltimore and receive that service, and PepsiCo is paying for the airfare. They're waiving the deductibles and they're waiving the copays, and while that's a wonderful benefit, if you look beneath the surface of the benefit itself, you have a payer, a very large payer in the form of PepsiCo, and you have a healthcare provider, highly respected academic medical center called Johns Hopkins, now coming together in a relationship, a very efficient relationship where the purchaser and the provider of the service are coming together. So that's where healthcare is going in this country, and through a combination of dumb luck and serendipity, here we are. Now, guiding our dumb luck and serendipity is our joint venture partner, which is Vanderbilt University Medical Center, who is very much on board through the Dione Center for Health Promotion, which is headed up by a brilliant guy by the name of Jay Groves. We've partnered with them to create some risk stratification algorithms, some very interesting surveying techniques that permit employers on a preemptive basis to identify who represents the high-risk individuals within their population. And then what our company is all about is then recognizing, and excuse me, Turney, for dominating this conversation.
No, I love this answer. Keep going.
Ask.
You did. I did. Keep going.
So, you know, we take a page out of Clayton McWhorter's book when years ago, you know, he, in a Khrushchev-like fashion, he's taking his fist and pounding it on the table, and he's saying, healthcare is delivered on a community-by-community basis. That's how it transacts. Well, that's what our company is all about. We take the local employer, the local healthcare provider, we put meaningful data between the two of them. We say, let's create that efficient distribution channel. Mm-hmm. Let's take those women that need those mammography screenings. Let's take those men that need those PSAs, and let's take those individuals who haven't had a physical exam, and let's distribute them locally using a primary care intervention to introduce potentially high-risk individuals to a white coat. Because we know that once we get that individual in front of the physician, and I want to qualify that because it could be a licensed, a family practitioner, it could be a nurse practitioner, whoever that qualified healthcare professional is. We know that once we get those two together, a meaningful transaction will take place.
So, who is your customer? Who is your client? Is it the employer?
In an extended way, yes. We contract directly with hospitals. Our company is all about going to the C-suite of the hospital and saying, guys, if you look down the road relative to what the federal government's going to be doing to Medicare and Medicaid, we can conservatively expect cuts. Since the introduction of the Balanced Budget Act back in 1996, hospitals have gotten as operationally as efficient as we have ever seen them. There's not a lot of meat left on the bone. Well, in the era of now saying you're now going to have the largest payer start reimbursing you less, Mr. CEO of the hospital, what's your strategy? You can't cut. You're going to get less reimbursement. We have more and more Americans going on the uninsured rolls. It's a dire situation. So we come to the table and we say, perhaps there's a solution by positioning your hospital not as a sick care provider, but truly as a healthcare provider. Go to those employers in your community, recognize the dilemma that we're being, and become the subject matter expert in the promotion of population health services within your community. With the belief that, Clayton McWhorter again, healthcare transacts on a community-by-community basis. Gradually, that word is going to spread through the Chamber of Commerce, through the Rotary, and by the way, many of the hospitals that we contract with are also the largest employers in their market. So they're dealing with all these issues too. Mm-hmm, mm-hmm. We want to foster the partnership between the employer and the provider in a meaningful way, so hence our clients are hospital systems that rebrand our product under their graphic standard. They take it to the employer and we're saying, you know what, we're going to change the equation because the way you look at us now, Mr. Employer, is our revenue is your expense. We want to change that dynamic. We want to level the playing field by saying, armed with the right information, we can also be part of the solution.
So what is your business model? How do you make money?
And we are, thank you. I'm pleased to say, from a very early point within the foundation of our company, Turney, you recall we incorporated in 2009 and we turned profitable very shortly thereafter. We have a superior management team. No, that's not true. We're going to get a lot better than that. But it's simple. We contract on typically for a 24, 36, or 48-month period of time with client hospitals who engage our services, build it into their what I would call their strategic direction, and we very much become a partner with them in not only guiding but leading their relationships with the employer.
So it's a subscription model?
It's a subscription model.
Okay,
correct.
All right. Bob, let me change gears just for a moment and let's think about you as an entrepreneur. We probably have a lot of people watching this today who aspire to start businesses, and you've started one, and apparently very successfully. And so I'm curious about your experiences with that. How did you get this business started? How did you finance it? How did you get it off the ground?
I would start by saying, if you're thinking, They say that entrepreneurs are individuals that have no idea of the odds that are against them, and it's very true. Boy, that's a great question, Turney, and that could comprise a show by itself. But how we started it's very simple. This is my second company. I had the opportunity through my first company to sit out a 12-month non-compete and spend a lot of time sitting on a bench over at the golf course thinking about where we wanted to go with this next venture. It was at that time where I contacted some pretty smart folks over at Vanderbilt who were, retooling their model and their product, and we decided we had something in common. That's where I met, again, Dr. Jay Groves and Dr. David Marin and the team over at the Diani Center, and we talked about this concept, and candidly, I think they're the best in the country at what they do relative to the promotion of health. And we put this thing together. So we launched it in 2009. It is financed largely by myself and Elliot Hauser, who is our Chief Information Officer and co-founder of the company. And it was just through the combined dint of our personalities that we got this thing up and running. We have a good enough reputation within the healthcare community where we went to some hospital CEOs and said, hey, are you interested in alpha siting and then ultimately beta siting? And they said absolutely. They provided some seed capital to get us going as well. So it was just sort of like the way a train leaves a station. Someone gets out and says, all aboard. Everybody gets aboard. It starts moving slowly, and gradually it's moving faster and faster and faster. And we're now, we're contracted with hospitals in 37 markets across the United States. Our clients are for-profit, not-for-profit, academic medical centers. And just within the state of Tennessee, we have Wellmont Health System in Kingsport. We have Covenant Health System in Knoxville, Erlanger Health System in Chattanooga. We're working with Mission Point Health Partners, which is Ascension Health's ACO here in Nashville, Tennessee. Murray Regional Medical Center, a very impressive group of folks down there led by Robert Otwell. And of course, Vanderbilt University Medical Center here. But we're in Richmond, Boca Raton, Dayton, Ohio, and we could go on into additional markets. But the experience has been a wild ride. They have been probably the best years in my life, because the one thing about being an entrepreneur is you are on the edge. The shots you call determine what happens to you the next day, and you've got to live by those decisions. And all within the context of that, my beautiful bride gave birth to twin boys 2 years ago, so it's been a pretty interesting time, largely led by just a passion for healthcare, where it's going in this country. Listening to these very smart clients that we have, and we haven't lost a client, and they're all coming back to us saying, and can you do this, and can you do this, and can you do this? So if you're saying, Bob, there are entrepreneurs out there thinking about doing this, I highly encourage it. Get ready. There's a lot of risk, heck of a lot of risk, but more importantly, listen to your customers, because they're going to tell you where the market's going, and if you do a good job there, and you bring that back into the tent, and you use that guidance to create your business model, you're going to enhance the likelihood of your success.
So at this point, the business is still in your hands and your partner's hands. Do you anticipate another round of private investment capital? Do you plan to take the company public?
The answer to that is we don't know, and I'll tell you our philosophy on that. The play is on the field. A lot of people spend time looking at the scoreboard. The scoreboard being the income statement, the balance sheet, statement of change, what's happening with the numbers. We're focusing on the quality of play on the field, because we believe that if we do a good job there, the scoreboard's going to take care of itself. Your question's very timely, however, because as I said previously, we're up and running, we have a client base, we have a proven product, we're expanding the product. All of the customers that have the ability to expand with us, such as the Hospital Corporations of America, are expanding with us, and we have 100% rate of renewal. That's a good environment. Profitability is where we want it to be. We've got a very good margin, so now we're saying, what's next? How are we going to ramp? Dumb luck and serendipity again. Just within the past 3 weeks, I've now had 3 phone calls from what I would call senior individuals in the investment banking community who have said, I've heard about you guys. In fact, I've heard about you a couple of times. I've gone to the website. I saw what you're doing. Sounds intriguing. How can we get involved? So Elliot and I are now saying, all right, we've created the base. We have the customers. We've got the numbers in a good position. Do we want to bring on this capital? Well, attorney, as you know, that brings on a whole bunch of other questions relative to bringing on a new partner. Who is that partner? What is the dilution? What is the cost of the capital? Is it traditional venture capital? Is it mezzanine capital? Do you want additional individuals on your board? If so, what do they bring to the table in terms of strategic growth? And by the way, that's where we wanted to be. We wanted to get to the company we wanted to get the company to the point where we created enough interest that that community would come to us. Because as you also know, the worst time to raise capital is when you need to raise capital. Right now, we're in a good position, and I'll tell you, the people that are calling us are the people that we hoped would, because they know healthcare. They bring more than capital to the table. They bring relationships. They bring knowledge. And just the tenor of the conversations we have with them is somewhat akin to the tenor of a conversation a young man might have with a grandfather. Son, here's what I can do to help you. Here's what I can do to help grow your company. As opposed to other environments that I have had experience in where the board meetings become very contentious and you're not hitting your numbers, and that's a world that we did not want to participate in this time.
And Bob, you're part of an interesting community within our community. You're one of a number of healthcare entrepreneurs who have emerged here in the healthcare capital of the United States. And so I wonder if you have any observations about how we could become a more fertile ground for healthcare entrepreneurism. How could we become the Silicon Valley of healthcare here in Nashville?
I think the answer to that is I think we already are the Silicon Valley. What I want to encourage the healthcare industry in this community to do is to recognize its roots. I want to go back to the Dr. Frisks of the world. First of all, thank them. What Jack Massey and Dr. Frisk did is revolutionary. Not only within industry, business and industry in general, but certainly within the healthcare community. And if we go back and we take a look at what they did, it was pure innovation. It was groundbreaking. It was never heard of before. And out of that comes this map of growth and splintering and of new companies and just this whole morphing into new industries. And if we remember that, if we go back to those roots and we say, we just can't take a model and try to make it, the next iteration of that same model, and then the next iteration of that same model. We truly have to be groundbreaking. And I want to couple that with a statement I said previously. It's the Wild West in healthcare again. So it's the perfect environment for a city like Nashville to say, we're going to completely change the healthcare delivery system in this country. I think applied health analytics and what Elliot and I with Jay Groves are creating is in that direction. I want to be very clear. I'm not comparing myself to Dr. Frist by any means. I wish I had his brilliance. But I think what we are doing is we're listening to the market and understanding what's going on and bringing it back to the table and coming back with a product that says we're going to completely change the dynamic. We're going to bring the purchaser of health services and the provider of health services and the payer of health services together in a meaningful partnership. The most efficient distribution that can be delivered. That's meaningful. That's what Nashville can be doing.
Well, let's talk about the employer's role in all of this. I'll drill a little deeper in that. Since you're talking about innovation, maybe we ought to attack the elephant in the room. Many people think that one of the reasons we spend more per capita on healthcare and get less than most Western nations in return is because the employer's in the middle.
Well, golly, I want to fight that ghost. We have the finest healthcare delivery system in the world. Prime Minister of Canada receives healthcare in the United States. The Crown Prince of Saudi Arabia receives health care in the United States.
Yeah, that's the clinical part of healthcare.
The clinical part, but we you listen to the political verve these days, and people are beating up the healthcare system. They're beating up the pharmaceutical industries. They're talking about for-profit healthcare and how what a crazy way to deliver healthcare within within any model. The reality of it is the pharmaceutical companies are conducting miracles daily, extending human life and the quality of human life. The healthcare delivery system is comprised of some of the brightest, most dedicated people that you'll ever meet. So we're not talking about the delivery of healthcare, we're talking about the financing of healthcare, how it's paid for.
Exactly right.
We're talking about how it's paid for. And I'm not sure, Attorney, that I have the answer for that within the context of, two guys sitting at a table and talking about it. But I can tell you there are some things that can be tightened up. I think the role that the insurance carrier, whether it's on a fully funded or a self-funded, can become more meaningful. I think that the way that hospitals, healthcare organizations position themselves can become more meaningful in terms of the role that they play. But I also think that we need to continue to encourage innovation within the industry. For example, what we're seeing with organizations such as CVS, Walgreens. CVS, for example, is taking its Minute Clinic model, and through Andy Grossman's vision up there is developing now on-site clinics. They're going to employers and saying, let us come in and help you handle this issue. Well, I think understand Walgreens through the Take Care model. Here locally, there's a guy named Ernie Clevenger, who is one of the leaders in this industry.
A Lipscomb alum, by the way.
A Lipscomb alum. Well, there you go. There you go. Yet another reason to go to Lipscomb. So Ernie and CVS and Walgreens are all out there going to these employers saying, we can help you with this. So what does that mean? That means expenses driving innovation. That means that the employers are starting to say, you know what? Even though our business is to fill a 55-gallon drum with chemicals, to put on a truck, to ship somewhere, we have to backward integrate into healthcare. We're going to take on that responsibility because that cost center is so great. In that environment, you have a huge dynamic to spur entrepreneurialism. Let's just hope we can keep the government out of the way. We can not over-regulate that, not overtax that. Let's hope that we can keep that a pure enough environment where entrepreneurs will run in and create solutions. Because I assure you, if we do that, it will happen.
So as we near this point where the baby boomers have reached full maturity and the clinical delivery of healthcare has extended life beyond really any expectation.
I read yesterday potentially lifespan hitting 150 years in the not too distant future.
So how would we ever afford that in this country? We're already bankrupt. How are we going to afford for people like me to go on the government rolls?
You're giving me credit for intelligence far beyond my ability to answer that question. My answer is to let the market be the market. The economic opportunity will be created and solutions will follow in its wake.
I think that's a very smart answer and probably the only real answer. But there are many fears, of course. People talk about rationing of health care. People talk about all kinds of dire outcomes, and those things may come to reality. The fact is that we are really bankrupt in this country, and we just won't admit it, and it's largely because of health care.
If it is driving, it's the largest part of the government's budget. There's no question, and it's only going to get bigger as the baby boom continues to march forward, and we continue to develop new technologies, new pharmaceuticals. Clearly, that's going to happen, but if we also look at what's happening in this country and we just sort of untie all the constraints that are on the public, private, the charitable sectors, we have huge organizations in this country that also get no credit for the management and delivery of healthcare services. You have the Catholic Charities, for example. You have virtually every faith-based institution in this country is providing some level of care to the homeless, the under or the uninsured. We have this huge charitable net that if we create the tax incentives, the tax structure, if we create the funding mechanisms that permit significant net worth individuals to make the appropriate contributions, we're going to see this country rally. This country is not the type of country that needs to have rationing. It's not the type of country that needs to have individuals on a board determining who gets the hip and who does not. That's not what we are about. If we will, again, just unleash technology, we unleash entrepreneurialism, we let the market take advantage and recognize the strength of the heart and the souls of what America is all about, it's amazing how the problems can come together and be coalesced and be addressed.
I don't guess you would consider running for president, would you?
Nope.
Let me ask one last question. We're about out of time. I know you, and I know your heart as well as your mind, I think. Bob, when it's all over and done with, when you think in terms of what you'd like put on that tombstone, how would you sum it all up for Bob Chamberlain?
You're taking a question that my father used to ask me, and I'll give you the answer that he gave me, which at the time absolutely made no sense to an 8-year-old boy, but here's what he said to me. He said, Bob, the average lifespan of an American, this was back then, is 72 years. And if you take 72 years and you multiply by 365 days, it's a pretty small number. I'm not sure exactly the math, but I think it's on order of, I don't know, 18, 19,000 days. When you look at it in that context, 19,000 days, that's not a very long period of time. So my father used to say, what's the quality of those days? Well, I'm 54 years old, and I did the math not too long ago. I have about 8,000 days left. That's not a lot. So my father used to say, here's what I want on my tombstone. And again, as an 8-year-old boy, I'm going, I don't get it. He said, he contributed. He made a contribution. So over that very short period of time, which is but a speck in the timeline of history, during that period of time, he made a contribution. So I have to articulate and repeat my father. I would want it to say to those that know me, and more importantly to my children, he contributed.
Bob, that's a great answer. You're a great friend of Lipscomb's, good friend of mine. Thanks for coming today.
It's been a pleasure.
My guest today has been Robert Chamberlain, who's the founder and chief executive officer of Applied Health Analytics. Thanks for joining us. Please join us again soon on Conversations with the Dean.